1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
You know, when you first sit down to study for an obstetrics nursing exam, you kind of open your textbook with this certain level of naive optimism.
Oh, absolutely. You think like, okay, fetal development, this should be pretty straightforward.
Right. You expect this really simple linear timeline, like week 1, this happens, week 2, that happens.
You expect it to read like a clean, well-organized instruction manual for building a piece of furniture.
Exactly. I mean, you know, insert tab A into slot B, and 9 months later, boom, you have a baby.
But that is the great myth of nursing school.
It really is.
You go in expecting this neat chronological checklist, and instead you were just hit with the biological reality of embryology.
Which is incredibly messy.
Highly messy. It's simultaneous, and it's full of overlapping timelines.
Yeah, and you turn to the specific sources we're looking at today, like pages 264 and 265 of your textbook, along with tables 5A, 5B, and 10.1, and that whole clean instruction manual illusion just completely shatters.
It really does. You aren't looking at a simple timeline anymore.
Not at all. You're staring at this diagnostic and developmental landscape that is, quite honestly, a murky soup of overlapping weeks.
That's a great way to put it.
Right.
Wow.
I mean, you've got microscopic cellular changes listed right next to massive anatomical milestones. And sometimes the textbook even seems to contradict itself from one table to the next.
Which is the absolute definition of diagnostic muddy waters.
Totally.
And for a nursing student who is staring down a high-stakes OB exam, looking at those tables can trigger immediate, intense overwhelm.
Oh, pure panic.
It feels like you're being asked to memorize a dictionary of random biological facts, but, you know, without any real context.
And that feeling of overwhelm is exactly why we're here.
Yeah.
So I want to officially welcome you to this deep dive, especially to you, the dedicated nursing student listening to this right now.
We see you.
We really do. We know you're probably drowning in flashcards right now, trying to brute force memorize when the mesonephros forms, or like when the liver stops making blood.
And our mission today is to act as your personal exam coaches.
Exactly. We're going to take these dense, chaotic tables on fetal organ development, and we're going to transform them into a high-yield, logical, week-by-week masterclass.
We're going to build this biological house from the foundation up, focusing only on what you actually need to know to pass.
Right. And I think the key word there is logical.
Absolutely. Because what is so fascinating about fetal development is that it is not just a random sequence of events you have to memorize.
The cascade. Right?
Exactly. It's a highly choreographed biological cascade. Everything happens for a specific survival-driven reason.
Oh, that makes sense.
Yeah, and once you understand the why, like why one system absolutely must trigger the next system to develop, you won't need to rely on rote memorization anymore.
You'll just inherently know what has to come next.
Right. If you know how the plumbing works, you don't have to memorize which way the water flows.
That is a perfect analogy. And more importantly for you listening, we aren't just going to teach you the biology. We are going to point out exactly how nursing instructors and NCLEX test writers use these specific textbook tables to trick you.
Because exam writers are incredibly predictable once you understand what they value.
Right. They don't care if you memorized a random trivia fact.
No, they want to know if you can safely prioritize information. They test to see if you can distinguish a critical, life-sustaining developmental milestone from, you know, a secondary interesting detail.
They're testing your clinical judgment, not just your memory.
Precisely.
So we're going to ditch the flashcard mentality today.
Yeah.
As we walk through this timeline, week by week, we're going to organically highlight the absolute must-know facts, the secondary context that helps it make sense, a few memory tricks to anchor the concepts, the clinical why behind the biology, and the classic exam traps you need to dodge.
That sounds like a solid plan.
So let's start at the very beginning of the structural build. Let's look at weeks 3 and 4. Logically, if you're building a functioning organism, you need a command center, so the central nervous system, and you need an engine, the cardiovascular system.
Right, the absolute basics.
But right out of the gate, looking at the provided text, I have to stop and push back.
Uh-oh. What's the roadblock?
Well, it's a blatant discrepancy. On page 264, the text clearly states that the neural tube forms in week 3.
Okay.
But then I flip over to table 5A, I look under the central nervous system column, and it says neural tube formation happens in week 5.
Ah, yes.
So as a student sitting at a testing center with a ticking clock, which one do I trust? I mean, this is exactly the kind of textbook contradiction that causes pure panic during an exam.
It is entirely understandable to panic when your primary source material gives you 2 different timelines for the exact same event.
Right. It feels unfair.
It does.
Yeah.
But this actually raises a vital point about how standardized tests are constructed. When there's a known discrepancy like this across different tables in a major textbook, the exam writers are acutely aware of it.
Oh, really? They know about it.
Oh, absolutely. They have teams of reviewers who catch these things.
So do they just throw the question out?
Not exactly. They just avoid testing the highly debated starting point. They won't give you a question where the options are week 3 versus week 5 for formation, because that just invites legitimate arguments from students contesting the exam grade.
Oh, that makes sense. They don't want the headache.
Exactly. Instead, test writers will focus on the conceptual consequence, or the undeniable fixed endpoint. If you look at table 10.1, it explicitly says the neural tube closes in week 4.
Okay, the closure.
Yes, that closure is the vital, highly testable event. The exam will focus on the fact that this central nervous system foundation is established and sealed incredibly early, usually before a person even realizes they're pregnant.
Okay, that makes so much sense.
Yeah.
So as a student, I shouldn't get paralyzed by the discrepancy. I need to focus on the biological imperative, which is the closure in week 4 and the early onset in week 3.
Precisely.
So let's officially dive into the specifics of week 3. What is happening on a cellular level here?
Well, in week 3, the embryo is microscopic, obviously, but the master blueprint is actively unfurling. The foundational building blocks of the entire body are being laid down.
Wow.
The most critical event, as we just discussed, is the formation of that neural tube, which will eventually become the brain and the spinal cord.
And the heart is starting to do something too, right?
Yes, we also see the very earliest primitive development of the heart and the gastrointestinal tract.
So the absolute critical takeaway for week 3 is the neural tube formation. To lock this in mentally, I have a trick. Think of the phrase, 3 is for the tree.
I like that.
Imagine the human nervous system as a giant, complex oak tree. The neural tube is the massive, thick trunk of that nervous system tree, and the seed for that trunk gets planted right here in week 3.
That is a great visual anchor, and clinically speaking, understanding why this early timeline matters is crucial for nursing practice.
Because it relates to defects.
Exactly. The neural tube is the absolute anatomical foundation. If that tube doesn't form correctly, or if it fails to close properly in the following week, it leads to devastating congenital anomalies.
Like spina bifida.
Right. We are talking about neural tube defects like spina bifida, where the spinal cord is exposed, or an encephaly, where major parts of the brain and skull fail to develop. The trunk of the tree has to be solid, or the branches can't grow.
And this leads directly into a classic exam clue. Test writers love to focus heavily on the fact that this central nervous system development starts incredibly early, in week 3.
They absolutely do.
Why? Because it highlights the absolute necessity for early folic acid supplementation.
Yes, that's the clinical tie-in.
Even though these specific tables don't scream folic acid in bold red letters, your instructors will expect you to link this week 3 neural tube formation directly to maternal nutrition.
Because if a patient waits until they are 8 weeks pregnant to start taking prenatal vitamins, the critical window for neural tube formation has already closed.
Right, it's too late. So they are testing the mechanism and the nursing intervention together.
Precisely. The intervention is preconception folic acid, because the mechanism neural tube formation happens in week 3.
Okay, so if you only remember one thing about week 3, it's that week 3 is when the neural tube, the future spinal cord, forms.
Yeah.
3 is for the tree.
Perfect.
Now, let's move into week 4, where the biology really starts to accelerate.
Week 4 is arguably one of the most clinically significant weeks in the entire first trimester. It is a period of explosive organogenesis.
Okay, let's look at the critical milestones. According to Table 5A, week 4 is when the heart begins to beat.
A huge moment.
And Table 10.1 adds that the 4 chambers of the heart are already formed.
Yeah.
And importantly, that neural tube we just discussed it officially closes.
Yes. And alongside those massive events, we also see the limb buds starting to grow.
Oh, like little arms and legs starting.
Exactly, just little buds.
Right.
The diaphragm and the lungs begin their initial formation. And the digestive and filtration organs, like the stomach, pancreas, liver, and urinary tract, they all begin to form.
The sheer volume of cellular differentiation happening in week 4 is just staggering.
It really is. But let's focus on the cardiovascular system for exam purposes.
Okay, I have a memory trick for this one that I think works perfectly. 4 equals 4 chambers plus the first flutter.
Oh, that's clever.
Right. In week 4, the 4-chambered heart beats. 4, 4, flutter. It links the week number directly to the anatomy and the action.
That is a great cognitive anchor. Now let's explore why this specific week matters so deeply from a physiological standpoint.
Okay.
The cardiovascular system is the very first organ system to actually function in the developing embryo. And if you think about the underlying logic of building a complex organism, it absolutely has to be the first.
Because you can't build a city without supply lines.
Exactly. The body is about to undergo massive, explosive growth in the coming weeks. Millions of cells are going to be dividing and differentiating rapidly.
And they need food.
Right. All of that cellular activity requires an immense amount of oxygen and nutrients, and it produces a significant amount of waste. Simple cellular diffusion isn't enough anymore.
So they need a pump.
Yes. The embryo needs a dedicated pump to push those nutrients through the developing vascular network. The heart beginning to beat in week 4 is the moment those critical supply lines are turned on.
Listen closely, because here is a massive exam clue for week 4. You will absolutely, without a doubt, see a question on your OB exam asking when the fetal heart begins to beat. The answer is week 4.
They love testing this because it marks the critical onset of independent functional circulation for the embryo.
However, you have to read the question stem with absolute precision.
Yes, you do.
Because test writers are notorious for trying to trick students by mixing up when the heart begins to beat versus when that heartbeat can actually pair with medical equipment.
That is a very common trap. We will cover the auditory milestones later, but for now, isolate this fact. The physical muscular contraction, the beating itself, begins in week 4.
So if you only remember one fundamental fact for week 4 is when the heart begins to beat.
Excellent.
Let's transition into the next phase of development. We've built the engine in week 4. Now in weeks 5 and 6, we need to establish the rhythm and connect the plumbing.
The transition from week 4 to week 5 is all about stabilization. The engine is sputtering to life, but now it needs to idle smoothly.
Okay, looking at week 5, the primary milestone is that the heart now beats at a regular rhythm. It's no longer just a primitive, uncoordinated flutter. It's a synchronized, reliable beat.
Exactly. And Table 5a also notes that the lungs are continuing to develop from the foregut.
We're also seeing finer details emerge, right? Like cranial nerves are becoming visible and muscles are starting to be innervated by the nervous system.
Yes, and Table 5b adds a really fascinating detail here. It notes that digestive system formation begins in earnest around week 5, but it explicitly states that this development continues all the way until toddler age.
Wait, really? I found that detail incredibly perspective shifting.
It is.
As adults, we tend to think of fetal development as this process that ends dramatically at birth. But the text is telling us that the gut is literally still under construction well into toddlerhood.
It really changes how you view pediatric nursing. Birth is just a change of location. The developmental biology continues uninterrupted.
That's wild, but let's bring it back to the cardiovascular system for week 5.
Okay.
A quick memory trick for week 5. 5 is alive. The heart graduates from a primitive starting flutter to finding its regular, reliable, alive rhythm.
I like that. And clinically, this transition to a regular rhythm is vital. It means the cardiovascular system is gaining the complex neurological and muscular coordination necessary to sustain long-term, continuous output.
Right, an irregular flutter can't support a full-term pregnancy.
Exactly. The regular rhythm ensures consistent perfusion of the developing tissues.
Which brings us to a classic, highly tested distractor trap. You had to distinguish between week 4, where the heart begins beating, and week 5, where the heart establishes a regular rhythm.
This is so important.
When you are taking your exam, do not rush. Read the stem of the multiple choice question incredibly carefully. If the question asks for the regular rhythm, you must select week 5.
I cannot emphasize that enough. Test writers intentionally design questions to punish students who skim. They will put week 4 as option A, and if you just read the word heartbeat and stop reading, you will get it wrong.
Yep, you have to look for the qualifying adjectives. Begins means week 4. Regular means week 5.
Always.
So the one thing to remember for week 5 is that regular heartbeat rhythm. 5 is alive.
Perfect.
Now, moving into week 6, we hit some incredibly interesting physiological quirks. The major milestone here is that fetal circulation is officially established. But then, Table 10.1 drops this detail. It explicitly states that the liver produces red blood cells.
Yes, it does.
Wait, I need you to explain this, because as a nursing student who just took adult med-surg, this feels completely wrong. The liver is for detoxifying blood and making bile. The bone marrow makes red blood cells. Why is the fetal liver suddenly acting like a blood factory? Is this a typo in the textbook?
It is absolutely not a typo. It is a vital quirk of embryology, and it is a massive testing point specifically because it seems so counterintuitive.
Okay, so why does it happen?
Well, to understand why the liver is making blood, we have to look at what else is happening in week 6. The central nervous system is advancing to the point where brain waves are detectable. But look at the skeletal system. The text notes that the primitive skeleton is just forming.
The key word being primitive.
Exactly. The bones are mostly just soft cartilage models at this stage.
Oh, I see.
The hollow cavities inside the bones, the medullary cavities where bone marrow eventually lives, they simply do not exist yet in a functional capacity.
Wow, okay.
So the embryo desperately needs a massive influx of red blood cells to carry oxygen through that newly established fetal circulation, but it doesn't have a functional bone marrow factory yet. So the liver has to step up.
It just takes over the job.
Right. It moonlights as the temporary hematopoietic or blood-producing organ. It bridges the biological gap until the skeletal system matures later in the pregnancy.
That is a brilliant logical connection. The skeleton is too soft and primitive to do the job, so the liver takes over out of pure necessity.
Exactly.
Also happening in week 6. The kidneys are developing from a structure called the mesonephros. Can you unpack that term for the listener? Mesonephros sounds like a dinosaur.
It does sound prehistoric, doesn't it? It's an embryological term that students often stumble over. Human embryos actually go through 3 different sets of kidneys during development.
3 sets.
Yes. The first set is non-functional and disappears almost immediately. The second set is the mesonephros, or the middle kidney. It acts as a temporary primitive filtration system during these early weeks.
Okay, and then what?
Eventually, it will degenerate as the final permanent kidneys, the metanephros, take over the job.
So it's another placeholder organ, just like the liver acting as a placeholder for the bone marrow. The body is using temporary tools to survive while it builds the permanent infrastructure.
That makes perfect sense. And Table 5A also notes that first movements can begin around week 6 or 7.
Oh, movements. But wait, it's crucial to note that these movements are microscopic muscular twitches. They are absolutely not felt by the pregnant person yet.
Right, not at all. It's purely visible on an early ultrasound.
Okay, so let's lock week 6 in with a memory trick. 6 equals circulation and cells. In week 6, the fetal circulation fully connects, and the liver makes those red blood cells.
The clinical significance of this week is profound. Once fetal circulation is fully established, the fetus can efficiently exchange nutrients, oxygen, and waste with the maternal system via the developing placenta.
Right, because before this point, the embryo relied heavily on simple diffusion, which is slow and limited.
Exactly. Establishing a dedicated pumped transport highway allows for the massive growth spurt that is about to occur.
And this leads right into a huge exam clue. I guarantee you will see a question that looks like this. During the first trimester, which fetal organ is primarily responsible for the production of red blood cells?
Such a classic question.
Option A will be bone marrow. Option B will be the yolk sac. Option C will be the spleen. Option D will be the liver. If you guess based on adult anatomy, you will pick A and get it wrong. The answer is the liver.
It is one of the most reliable questions instructors use to separate a student who truly studied fetal development from one who is just relying on generalized anatomical knowledge.
If you only remember one thing for week 6, fetal circulation connects, and the liver makes the blood. Boom. Done.
Let's keep building this house. We are moving into weeks 7 and 8, which is the completion of the blueprint.
At this point, the major systems are running, the heart is pumping, the blood is flowing, but the architectural structures themselves are still quite primitive.
Yes, but as we move through weeks 7 and 8, we hit a massive structural milestone. The foundational blueprint is officially and fully drawn.
Going back to our house building analogy, what does this mean? It means by the end of week 8, you have finished all the rough framing, the 2x4s are up, the plumbing pipes are laid in the walls, and the electrical wires are run.
The core structure is entirely there.
Right. After week 8, you're not building new rooms anymore. You're just putting up drywall, painting, and moving in furniture. The complex foundational construction phase is over.
That analogy perfectly captures the transition from the embryonic period to the fetal period. Let's look closely at week 7 to see how those final structural details come together.
Okay, for week 7, the absolute critical detail, the need to know from table 5b, is that urine production begins.
Which is fascinating.
And alongside that, table 10.1 shows the physical shape of the embryo is rapidly changing. The trunk is straightening out of that tight, characteristic C shape.
The arms and legs are actually starting to move too. The diaphragm is fully formed. The mouth develops lips and early tooth buds.
And look at the heart in table 5a. It notes the formation of the foramen secundum and the foramen ovale. These are absolutely critical shunts for fetal circulation.
I want to pause on those shunts because fetal circulation is a notorious weak point for nursing students.
It really is. I mean, why does a developing fetus need whole shunts in its heart? If an adult has a hole in their heart, it's a medical emergency.
It's all about the lungs. In an adult, the right side of the heart pumps blood to the lungs to pick up oxygen, but a fetus is floating in a sac of amniotic fluid.
It isn't breathing air.
Right. The fetal lungs are essentially collapsed, fluid-filled sacs that provide enormous vascular resistance. They aren't oxygenating anything. The oxygen is coming from the mother via the placenta and the umbilical vein.
So sending a massive volume of blood to the fetal lungs is just a waste of energy.
Exactly. The fetal body is incredibly efficient. So it creates bypass valve shunts. The foramen ovale is a literal trapdoor between the right and left atria of the heart.
A trapdoor. That's a great visual.
It allows highly oxygenated blood arriving from the placenta to bypass the right ventricle and the lungs entirely, shunting directly over to the left side of the heart so it can be pumped straight out to the developing brain and body.
That is fascinating. The anatomy physically adapts to the aquatic environment of the womb.
It really does.
Okay, let's give a memory trick for week 7. 7 equals secretions. This is the week urine secretion begins.
Now, let's connect why urine production in week 7 is so fundamentally important. It sounds like a minor detail, but it's crucial. Fetal urine eventually becomes a major essential component of the amniotic fluid.
Wait, let me trace that logic. If the kidneys start making urine and the baby's floating in a closed sac of amniotic fluid, does that mean the fluid is mostly just fetal urine?
By the second half of the pregnancy, yes, it is. And that is a good thing.
Wow.
The fetus continuously swallows the sterile amniotic fluid, which is largely its own urine, and then excretes it back out. This continuous cycle of swallowing and excreting is how the fetus practices functioning its gastrointestinal tract and its renal system.
So they are practicing plumbing, basically.
Exactly. Furthermore, drawing that fluid into the developing lungs is critical for lung tissue expansion and development.
Which sets up a very difficult high-level synthesis question for an exam. Instructors know that amniotic fluid relies on fetal urine.
Yes, they do.
So they might give you a clinical scenario where an ultrasound shows oligohydramnios, which is an abnormally low volume of amniotic fluid later in the pregnancy. They will ask you which fetal organ system might be malfunctioning.
And if you don't connect fetal kidney function, which starts here in week 7, to amniotic fluid volume, you will miss the question.
Right. If the kidneys don't produce urine, the fluid levels drop dangerously low.
That is exactly how NCLEX-style questions are constructed. They don't just ask what happens in week 7. They ask you to connect the physiological onset of urine production to the overall environmental health of the womb later on.
If you only remember one thing for week 7, urine production starts. 7 equals secretions.
Now brace yourself for week 8. This is a heavy hitter in the world of OB nursing.
Week 8 represents a monumental shift. Is the dividing line between the embryonic period and the fetal period.
Yes, the major milestone for week 8 is that organogenesis is complete. Every major organ system has been laid down.
Which is huge.
Additionally, the placenta is officially working and taking over the hormonal maintenance of the pregnancy.
Physically, the embryo now actually resembles a human being. The intestines are rotating into their proper position. Facial features are refining.
The external genitalia begin to form, though you can't quite tell the biological sex just yet on an ultrasound.
And the eyelids form, but they are tightly sealed shut to protect the developing optical nerves.
Let's focus on that term, organogenesis. It literally means the creation of organs.
I have a simple rhyme for this. 8 is great, organogenesis is complete.
I love that. The clinical implications of week 8 are massive because the framing of the house is done, because all the major organ structures are now physically formed. The developing fetus experiences a shift in vulnerability.
Okay, a shift in vulnerability. Tell me more.
During those incredibly fragile early weeks, from week 3 to week 8, the cells were rapidly differentiating. If a teratogen, like a harmful drug, a virus, or radiation, is introduced during that early window, it can completely halt the formation of a major limb or organ.
Right, because things are just starting.
Yeah.
But after week 8, the organs are just growing larger, right? They aren't forming from scratch anymore.
Exactly. The fetus is still vulnerable, of course, but the risk shifts. A teratogen exposure after week 8 is more likely to cause physiological dysfunction or growth restriction rather than gross structural abnormalities like a missing arm or a malformed heart.
Okay, so the critical period of structural vulnerability officially ends at week 8.
Yes.
That is a massive clinical point. And here is your exam clue. When is organogenesis complete is a classic, highly tested, guaranteed to see it nursing school question.
Always.
The answer is unconditionally 8 weeks. Another heavily tested fact from this week. This is the timeline when the placenta is fully working and taking over the production of progesterone to sustain the pregnancy.
If you miss the organogenesis question on an exam, you are giving away free points. Lock week 8 into your brain.
If I only remember one thing for week 8 marks the completion of organogenesis. 8 is great.
We are cruising now. Welcome to the second trimester transition.
We are looking at weeks 9 through 12, which the tables group together as a milestone month. We've officially graduated. We're no longer calling it an embryo. We have a fetus.
The house is built, the foundation is poured, and now it's time for differentiation, refinement, and practice.
These weeks are characterized by rapid, proportional growth and the maturation of those systems that were laid down in the previous 8 weeks.
Let's hit the major milestones for weeks 9 through 12. The most socially famous milestone happens at week 12. Fetal sex can be determined by an ultrasound.
That is huge for expectant parents.
It is. But physiologically, Table 5b notes something incredibly important. The fetal pancreas can produce insulin and glucagon starting around week 9.
We also see the urogenital tract completing its structural development.
The secondary details in this time frame are also fascinating. The fetal immune system gets a kickstart with B lymphocyte production starting at week 9.
And the teeth, right?
Yes. The buds for all 20 temporary baby teeth are laid down in the BEMS. Proportionally, the fetus looks a bit top-heavy. The head makes up nearly half the entire size of the body.
The digits, fingers, and toes are well formed, and the digestive system actually begins to show activity.
Now, I have a question about movement here. The sources note that the fetus moves, kicks, and swallows during this 9 to 12-week block.
Right.
But I'm putting myself in the shoes of a pregnant patient. Can the pregnant person actually feel those kicks yet? Because 12 weeks seems really early to feel a baby move.
You've hit on a vital distinction that nursing students must master to pass their boards. The answer is no, the pregnant person cannot feel it yet. We must clinically differentiate between ultrasound detectable movement and maternally perceived movement.
Which are two very different timelines.
Completely different. As we saw, microscopic movement begins as early as week 6 or 7. By weeks 9 to 12, the fetus is actively kicking, flexing, and doing backflips in the amniotic fluid.
Right.
But the fetus is still incredibly tiny, only a few inches long, and it is buffered by a relatively large volume of fluid. The muscular force of the kicks simply isn't strong enough to transmit through the amniotic fluid, through the uterine wall, and into the mother's sensory nerves.
The movement at this stage is strictly observable via ultrasound technology.
Okay, that clears up a lot of confusion. Let's do our memory trick for this block. 12 equals tell. By week 12, the external genitalia have differentiated enough that you can tell the biological sex on an ultrasound.
Let's examine the deeper physiological why for this period, specifically regarding the pancreas. The social milestone of finding out the sex is exciting, but the endocrinology of week 9 is critical for fetal survival.
Okay.
The ability of the fetal pancreas to produce its own insulin and glucagon is a major turning point for fetal metabolism.
How does that impact the pregnancy, especially if the mother has gestational diabetes?
It becomes a massive factor. Here is the physiological rule. Maternal glucose sugar freely crosses the placenta to feed the baby, but maternal insulin does not cross the placenta. The molecules are too large.
So the fetus has to produce its own insulin to manage the sugar load it receives from the mother.
Oh, wow. So let me trace this. If a mother has poorly controlled diabetes, her blood sugar is high. That high sugar crosses the placenta and floods the fetal bloodstream.
Yes.
The baby's brand new week 9 pancreas suddenly has to work in absolute overdrive, pumping out massive amounts of fetal insulin to handle all that excess maternal sugar.
Exactly. And insulin is a primary growth hormone for a fetus. When the fetal pancreas pumps out excessive insulin, The fetus stores all that extra sugar as fat.
leading to a big baby.
Right. This leads to a condition called macrosomia, where the baby grows dangerously large, which can cause severe complications during a vaginal delivery, like shoulder dystocia.
That is a brilliant physiological connection. Understanding that week 9 pancreatic milestone explains the entire pathology of a diabetic pregnancy.
Okay, exam clue for weeks 9-12. Instructors love to ask when parents can realistically find out the sex of the baby via an anatomical ultrasound. According to your specific textbook source, the answer is week 12.
A word of warning for students. Do not let real-world anecdotes confuse your test answers. You might have a cousin who found out the sex at 9 weeks using a specialized maternal blood test that looks for fetal DNA.
Very true.
That is modern clinical practice, but it is not what this specific textbook table is teaching. Always answer based on the provided text, which relies on anatomical visualization. The answer is 12 weeks.
Stick to the book to pass the test. If you only remember one thing for weeks 9-12, fetal sex can be determined by week 12. 12 equals tell.
Moving right along into the next block, covering weeks 13 through 16, the fetus is growing exceptionally fast now.
According to Table 10.1, the weight of the fetus actually quadruples in this short window.
With that rapid increase in size comes an increase in muscular strength, leading to one of the most exciting and highly tested clinical milestones for the pregnant person.
It is a profoundly emotional time in the pregnancy, but also a vital diagnostic marker. Let's look at the key events.
The biggest milestone by far is quickening. This is the moment when fetal movement is finally detected and felt by the pregnant person.
Finally.
Additionally, Table 5b tells us that maternal Ig transfers to the fetus starting at week 16. And structurally, the fetus starts actively swallowing amniotic fluid at week 16.
Looking at the secondary details, the fetal skin is developing, but is still almost entirely transparent. The fetus is actively making sucking motions with its mouth, practicing for breastfeeding.
Fingernails and toenails are present, the pinna, or the external ear anatomy, is recognizable, and the cellular immune system advances with T lymphocyte production starting around week 14.
I want to focus on this fascinating detail about the maternal IgG transferring at week 16. When I read this, it literally sounded like the pregnant person is sending over a software security update to the baby.
Software security update is actually a remarkably accurate analogy for passive immunity.
Can you break down what IgG actually is for a student who might not have taken microbiology recently?
Certainly. IgG stands for immunoglobulin G. It is the most common type of antibody found in human blood. Antibodies are proteins created by the immune system to fight off specific infections, like viruses or bacteria.
Okay, makes sense.
Now, a developing fetus has a completely naive immune system. It hasn't been exposed to the outside world, so it hasn't built up any of its own antibody defenses. However, the maternal IgG molecules are incredibly small enough to physically cross the placental barrier.
So the mother is literally uploading her own immune history into the fetal bloodstream.
Precisely. She is bestowing her immunological memory onto the fetus. If the mother has immunity to measles or chickenpox, she passes those specific IgG antibodies to the baby.
Which is called passive immunity.
Right. It protects the fetus while it is in utero. And critically, those antibodies remain in the newborn's system for the first few months after birth, protecting the vulnerable infant until its own immune system can come fully online.
That is just incredible biological engineering. Let's do a memory trick for weeks 13-16. 16 equals swallowing and security. At week 16, the fetus swallows amniotic fluid and it gets that security update, the IgG antibodies from mom.
And for the movement, remember the phrase quickening in the teens. It happens right here in the 13 to 16 week window.
Let's discuss why this week matters clinically. Quickening is a massive historical and clinical milestone.
Why historical?
Before the invention and widespread use of obstetric ultrasound, quickening was one of the primary ways a doctor could confirm fetal well-being and help accurately date the pregnancy. If a mother reports feeling movement, the provider knows that the central nervous system and the musculoskeletal system are intact, functioning, and communicating.
And what does quickening actually feel like? I know students often get asked to describe it to patients.
It doesn't feel like a sharp kick initially. Because the fetus is still relatively small, early quickening is often described by patients as a faint fluttering sensation, almost like butterfly wings brushing against the inside of the abdomen, or sometimes like tiny gas bubbles popping.
And the swallowing of the amniotic fluid, why is that important?
It is essential for the maturation of the gastrointestinal tract. The gut needs that fluid passing through it to stimulate the development of the mucosal lining and to learn the mechanical process of peristalsis, the muscular contractions that move food through the digestive system.
Here is a gigantic exam clue for this block. Quickening is an absolute top-tier, must-know NCLEX keyword. You have to memorize that it happens in this 13-16-week window.
Definitely.
Now, word of caution. If you look at older textbooks or ask a veteran labor and delivery nurse, they might tell you quickening happens later, maybe 16 to 20 weeks, especially for first-time mothers.
But on a standardized exam.
Exactly. On an exam based on this specific textbook source, you must stick to the provided table. The table says 13-16 weeks, mark 13-16 weeks.
And test raters will try to confuse quickening with that early ultrasound movement we discussed. Know the exact definition. Quickening is specifically maternally perceived movement.
If you only remember one thing for weeks 13-16, this is when the pregnant person finally feels the baby move, which is called quickening.
All right, take a breath. We are moving into weeks 17 through 20. The fetus is getting much bigger now, and because it is constantly floating in a bath of amniotic fluid, it needs some serious protection. Plus, we hit another highly tested diagnostic milestone regarding the heart.
Let's outline the core milestones. Table 10.1 tells us that during week 17-20, fetal heart tones can finally be heard with a standard acoustic stethoscope.
We also see the appearance of two very specific, highly tested dermatological features. Vernix caseosa and lanugo.
Hold on, let me stop you right there. I have to play the role of the frustrated, confused nursing student again.
Okay, go for it.
In week 4, the text said the heart begins to beat. In word 5, it said it has a regular rhythm. But now, in week 17-20, it says fetal heart tones can be heard with stethoscope. Why is this distinction so incredibly important? It feels like the textbook is repeating itself just to trip me up on a test.
It feels like a trick, but it's actually a lesson in medical technology and fetal growth. You must break down the specific tool being used to assess the heart.
Okay.
In week 4 and 5, the heart is physically beating, but it is microscopic. It is the size of a poppy seed.
Oh.
We can only visualize that pulsation using a transvaginal ultrasound probe.
Right.
Later, around 10 to 12 weeks, the heart is slightly bigger, and we can hear it using an electronic fetal Doppler, which uses technology to artificially amplify the sound waves.
But a stethoscope doesn't have a battery or an amplifier.
Exactly. An acoustic stethoscope relies purely on the organic volume of the sound. It isn't until this 17 to 20 week window that the fetus is physically large enough and the heart muscle is strong enough that a provider can place a simple unamplified stethoscope on the mother's abdomen and organically hear the heart valve snapping shut.
Ah, so it's an anatomical size issue dictating the technological tool. Ultrasound sees it first, Doppler amplifies it next, and finally the stethoscope hears it organically. That is a phenomenal distinction to understand. What else is happening in weeks 17-20?
Looking at the secondary details, we see rapid brain growth. The kidneys continue to secrete urine, but now the text explicitly notes they're secreting it into the amniotic fluid. Brown fat is beginning to be deposited, eyebrows and head hair appear, and the fetal muscles are well developed.
Let's do a memory trick for this stage. 20 equals tones and temperature. Heart tones are heard with a stethoscope, and brown fat is deposited for temperature regulation.
Let's explore that brown fat, because understanding its function is vital for neonatal nursing. Brown fat is a specialized type of adipose tissue. Why does the fetus need it? Because newborn babies, unlike adults, cannot shiver effectively to generate muscle heat.
So if a baby gets cold, they can't warm themselves up by shivering.
Correct. Instead, they rely entirely on a process called non-shivering thermogenesis. They chemically metabolize this specialized brown fat to generate body heat after birth. It is a critical survival mechanism.
If a baby is born prematurely, before these brown fat stores are adequately laid down in weeks 17-20, they are at massive risk for life-threatening hypothermia.
And what about the vernix and lanugo? What are those?
Vernix caseosa is a thick, white, greasy, cheese-like substance that coats the fetal skin. Lanugo is a very fine, downy hair that grows all over the body, and its primary job is actually to help hold the slippery vernix onto the skin.
Why does the baby need to be covered in grease?
Because it is submerged in a bath of amniotic fluid for 9 months. Imagine sitting in a bathtub for 9 months. Your skin would become completely macerated and break down. The vernix acts as a waterproof protective barrier, keeping the developing skin intact and healthy.
Nobody wants 9-month prune fingers. That makes total sense. Here is your exam clue for weeks 17-20. Instructors love testing terminology. Know exactly what vernix, the protective grease, and lanugo, the fine hair, are, and know that they appear here.
And as we grilled down on earlier, read the heart rate questions with extreme care. Be careful to specify that heart tones via an acoustic stethoscope are heard at 17-20 weeks, not earlier.
If you only remember one thing for weeks 17-20, vernix, lanugo, and stethoscope audible heart tones appear between 17 and 20 weeks.
Excellent. Now I want you to take a deep breath and focus because we are entering what is quite possibly the most critical physiological turning point in the entire pregnancy.
We are looking at weeks 21 through 24, and this is the surfactant milestone. We are crossing a critical threshold for viability.
The fetus is preparing the single most important system for extradarn survival, the respiratory system.
Up until this point, the lungs have been developing anatomically, but they haven't been functionally necessary because the placentas have been doing all the gas exchange.
But if this fetus is going to have any hope of surviving outside the womb, the lungs have to undergo a massive biochemical maturation. Let's look at the milestones.
The massive neon flashing lights milestone from table 10.1 is that the lungs begin to produce surfactant.
We also see that the alveoli, the tiny air sacs in the lungs, are forming. And table 5a notes that by week 24, the central nervous system has advanced enough that the fetus can actually hear and see.
For context, we also see the eyebrows and eyelashes becoming well-formed. The fetus develops a hand grasp and a startle reflex. The skin is translucent and red, and the eyelids, which fused shut back in week 8, finally begin to unseal at the end of this period.
I want to spend significant time on surfactant because I know from experience that nursing instructors are absolutely obsessed with it. Let's use an analogy to explain the physics of what surfactant actually does.
Okay, lay it on me.
Think about a plastic grocery bag that is wet on the inside. If you try to open that wet bag, the thin plastic sides stick tightly together because of the surface tension of the water. It's incredibly hard to pull apart.
That is exactly what the alveoli in the fetal lungs are like. They are tiny, wet, collapsed balloon sacs.
Right, so if a premature newborn tries to take a breath and those wet alveoli are stuck tightly shut due to surface tension, the infant doesn't have the immense muscular strength required to pull them open.
The lungs just collapse. They can't expand to take in air.
Surfactant is essentially a biological dish soap. It acts as a lubricant that breaks that surface tension, allowing the wet sides of the alveoli to slide apart so the lungs can inflate and deflate smoothly with minimal effort.
That is a flawless, clinically accurate analogy. Without surfactant, every single breath requires an exhausting amount of pressure to pry those stuck alveoli open. The premature infant rapidly burns through its energy reserves, the lungs collapse with every exhalation, and they quickly spiral into severe respiratory distress syndrome.
So a memory trick for weeks 21-24. 24 is surfactant's door. The door to theoretical lung viability officially opens as surfactant production begins.
And that leads directly to why this specific week matters so much in clinical practice. Surfactant production is the defining physiological factor in fetal viability.
Viability is defined as the point at which a fetus has a theoretical chance of surviving outside the uterus with intensive neonatal medical support.
Before 21 to 24 weeks, the lungs simply cannot exchange oxygen no matter how advanced the ventilators are, because the surfactant chemical simply doesn't exist yet to keep the alveoli open.
And here is a massive, flashing red light exam clue. The timeline provided in this table is a classic trap. Your source specifically says the lungs begin to produce surfactant here. They are starting the factory lines. They are not mature yet. When you're sitting in your exam, look closely at the verbs. Begins versus mature.
If the question asks when fetal lungs are considered mature, and you pick 24 weeks, you will get it wrong.
It is the single most common pitfall for nursing students in the OB module. Do not conflate the initial start of biochemical production with functional maturity. They are weeks apart.
If you only remember one vital thing for weeks 21-24, surfactant production begins between 21 and 24 weeks. 24 is surfactant store.
Moving forward to weeks 25 through 28, the fetus has the basic biochemical survival tools brewing. Now it's time to get into a physical position for birth and shift internal operations to adult-like functions.
Let's outline the core milestones for 25-28 weeks. Table 10.1 states that blood formation shifts from the spleen to the bone marrow. Also physically, the fetus usually assumes the head-down position in the uterus.
Let me pause you on that blood formation point. The text says, blood formation shifts from the spleen to the bone marrow. But earlier, when we talked about week 6, we specifically made a huge deal about the liver making the blood.
We did.
Now, the source is mentioning the spleen and the bone marrow. Can we trace this whole blood-making journey for the listener? I want to make sure the complete physiological timeline is crystal clear so they don't get confused by the different organs.
I'm glad you caught that because tracing that physiological shift is a high-level synthesis concept that really impresses nursing instructors. Here is the complete journey of fetal hematopoiesis, or blood creation.
Okay, tracing it out.
Early on, around week 6, the skeleton is entirely primitive cartilage, so the liver takes on the heavy lifting of making red blood cells. As the fetus grows into the second trimester, the spleen matures and starts assisting the liver in blood production.
Yeah.
Finally, here in weeks 25 to 28, the skeletal system is calcified and the internal bone cavities are mature enough to take over. So the primary site of blood formation shifts away from the spleen and liver and permanently into the bone marrow, which is where it will stay for the rest of the person's life.
That is fantastic clarity. Liver, then spleen, then bone marrow. Okay, looking at the secondary details for weeks 25-28. The fetus reaches a length of about 15 inches. There is brow formation and rapid brain development.
The nervous system starts exerting tighter control over body functions. Fingerprints are definitively set. Subcutaneous fat becomes visible under the skin.
Eyelids can open and shut freely, and the fetus can frequently be seen sucking its thumb on an ultrasound. Also, Table 5A notes the sense of taste has developed enough to respond to stimuli around a week 28.
Let's provide a memory trick for this stage. 28 equals head weight. The rapidly developing brain makes the fetal head proportionally heavy, which naturally causes the fetus to gravitate downwards into the vertex, or head-down position due to gravity.
Why this week matters is largely mechanical, assuming that head-down position is crucial preparation for a normal, uncomplicated vaginal delivery.
If the fetus doesn't naturally turn head down by term, the patient faces a breech presentation. A breech delivery complicates labor significantly, increases the risk of cord prolapse, and often necessitates a cesarean section.
And the exam clue here circles back to the blood journey we just discussed. The shift of blood formation to the bone marrow is a highly specific physiology question that separates the deeply prepared students from the ones who just skimmed.
Most students will remember the liver making blood in week 6, because it's weird, but they forget the final physiological shift to the marrow in weeks 25-28.
If you only remember one thing for weeks 25-28, the fetus assumes the head-down position.
We're entering the third trimester now, covering weeks 29 through 32. The structures are built, the systems are online. Now it's all about bulking up, storing nutrients, and doing practice runs for the harsh reality of the outside world.
Let's examine the major milestones for 29-32 weeks. Table 10.1 explicitly states that the lungs are not fully mature. I want to emphasize that. However, it also notes that rhythmic breathing movements occur.
I have to point out what feels like a massive contradiction to a stressed student. The text says rhythmic breathing movements occur, but literally right beneath it, it screams, lungs are not fully mature. How is the fetus breathing if the lungs aren't ready?
It's an excellent observation, and the key word to focus on is movements. The fetus is not exchanging oxygen. The amniotic fluid doesn't contain breathable oxygen, and the placenta is still completely handling gas exchange.
Right.
The fetus is essentially doing physical therapy. It is exercising the diaphragm and the intercostal muscles of the chest wall. It is pulling amniotic fluid in and out of the lungs to physically stretch the tissue and build muscle tone.
So it's a dress rehearsal for the big game.
Exactly. The muscles are practicing, but the biochemical machinery, the amount of surfactant available, is still not sufficient to keep the alveoli open during a real birth.
So it's practicing the motion, but the chemistry isn't there yet. Got it.
Okay, looking at the other details for weeks 29-32, there is a rapid increase in the amount of body fat. The central nervous system gains even more control over body functions. The pupillary light reflex is present, meaning the pupils will constrict in response to bright light shining through the maternal abdomen. And crucially, the fetus stores massive amounts of iron, calcium, and phosphorus.
Let's establish a memory trick. 32 equals storing for you. The fetus is aggressively storing fat, iron, calcium, and phosphorus.
Let's discuss why this week matters so much for maternal health. That mineral storage is no joke. The fetus is acting like a biological parasite.
It really is.
It is aggressively pulling iron and calcium directly from the pregnant person's bloodstream and skeletal reserves to build its own solid bones and a robust blood supply for after birth. This physiological fact is exactly why maternal prenatal vitamins, specifically those heavy in iron and calcium, are so incredibly crucial in the third trimester.
Exactly. If the mother's dietary intake is insufficient, the fetus doesn't just stop growing. It will literally leach calcium from the mother's teeth and bones and strip the iron from her red blood cells, leaving the mother severely anemic, fatigued, and physically depleted.
The nurse must relentlessly educate the patient on third trimester nutrition.
And the exam clue for this week focuses on exactly what we clarified earlier. Test writers love to trick you into thinking that rhythmic breathing movements mean the baby is ready to be born. Per the text, at weeks 29-32, the lungs are not fully mature.
If a patient comes into triage in premature labor at 30 weeks, the nursing priority is still anticipating respiratory distress for the infant and potentially administering maternal corticosteroids to artificially speed up that fetal lung development.
If you only remember one thing for weeks 29-32, there is a rapid fat increase and massive mineral storage. But remember, the lungs are still not mature.
Which brings us to the grand finale, weeks 33-39, the final stretch to term. This is the final coat of paint, the final security checks, and the ultimate green light for birth.
Everything we have discussed culminates in these final weeks. Let's look at the critical milestones by combining our tables.
From Table 5A, we see the most anticipated milestone. From week 34 onward, surfactant is fully present and lung maturation is considered almost complete.
From Table 10.1, the fetus is officially considered full term at 39 weeks. And from Table 5B at week 36, there is sufficient transfer of maternal IgG to ensure passive immunity.
Let's pause and highlight the lung timeline. Back in weeks 21-24, surfactant began production. Now we have the definitive answer for when it is actually ready to support life independently.
Week 34 is the magic number. Week 34 is when surfactant is present in sufficient quantities that lung maturation is considered complete enough to prevent severe respiratory distress. That is arguably the most critical timeline concept in all of OB nursing.
Let's look at the secondary refinement details for these final weeks. The fine lanugo hair that covered the body mostly disappears. In male fetuses, the testes descend into the scrotum.
The cartilage in the earlobes becomes fully formed and firm. Fingernails reach the very ends of the fingertips. Small breast buds are present on both male and female fetuses due to the influx of maternal hormones. And Table 5B notes, the fetal liver is finally able to conjugate bilirubin at week 36.
Okay, memory trick for the final stretch. 34 equals breathe more because the surfactant is mature, and 39 equals finish line because the fetus is full term.
Why this week matters cannot be overstated. It dictates almost every clinical decision made at the end of a pregnancy. The knowledge that lungs are mature at 34 weeks and the baby is full term at 39 weeks changes the entire medical calculus of labor.
If a patient comes in contracting at 32 weeks, the medical team fights aggressively with medications to stop the labor because the lungs aren't ready. But if a patient comes in contracting at 35 weeks, knowing the lungs reached maturity at 34 weeks, the provider might just allow the labor to progress naturally. The lung timeline dictates the intervention.
And your exam clue here is absolute gold. 39 weeks equals full term. Do not get tricked by older, outdated definitions of 37 or 38 week that you might hear veteran nurses talk about on the floor.
The medical definitions changed a few years ago. Your textbook source explicitly says in black and white, considered full term at 39 weeks, mark 39. And as we just drilled into your head, week 34 is the absolute magic number for surfactant maturity.
If you only remember one thing for this final block, lungs mature around week 34, and the fetus is full term at 39 weeks.
Wow. We just built an incredibly complex human being, starting from a single microscopic neural tube all the way up to a full-term infant with mature lungs and a working immune system.
But as your exam coaches, we know that simply hearing a chronological timeline once isn't enough to cement it for a board exam. We need to reinforce these concepts. So we're going to transition into our highly focused review sections. We're going to synthesize everything we just taught you into actionable, testable formats.
Repetition is the mother of learning. We are going to reorganize the data so your brain recognizes the patterns, no matter how the test writer approaches the topic.
Let's kick off with bonus section A, the biggest exam milestones. Instead of going week by week, we are going to rapidly volley the absolute most critical, high-yield physiological events in chronological order, isolating just the major turning points. Follow the logic of the build. Ready.
Ready. It all starts with the engine, week 4.
The fetal heart begins to beat.
Next major structural shift, week 8.
The blueprint is done. Organogenesis is complete.
Moving to external anatomy, week 12.
Fetal biological sex can finally be determined by ultrasound.
The neuromuscular connection, weeks 13 through 16.
Quickening, that first definitive movement, is felt by the pregnant person.
The start of respiratory viability, weeks 21 through 24.
Surfactant production begins in the alveoli.
The completion of respiratory readiness, week 34.
Surfactant is abundant, and the lungs are structurally mature.
And finally, the finish line, week 39.
The fetus is officially full term and ready for delivery.
Excellent. That gives you the broad strokes. Now let's drill down into the specifics with bonus section B, the top 10 testable facts. If you are sitting in your car in the parking lot of the testing center and you have exactly 5 minutes before you have to walk in, these are the mental flashcards you need to review. Listen very closely.
Fact 1. Organogenesis, the critical period of structural formation and highest teratogen vulnerability, finishes entirely at week 8.
Fact 2. The placenta is fully operational and sustaining the pregnancy by week 8.
Fact 3. Fetal circulation, the internal highway system, is established in week 6.
Fact 4. Hematopoiesis is dynamic. The liver makes red blood cells in early pregnancy around week 6, but shifts the job to the bone marrow late in pregnancy around weeks 25-28.
Fact 5. Fetal sex is visible on an anatomical ultrasound by week 12.
Fact 6. Quickening is the maternally perceived fetal movement, and it occurs between weeks 13 and 16.
Fact 7. Fetal heart tones can be heard organically via an acoustic stethoscope between weeks 17 and 20.
Fact 8. The critical lung lubricant, surfactant, only begins production between weeks 21 and 24.
Fact 9. Lung maturation is considered almost complete, and surfactant is fully present at week 34.
Fact 10. According to current guidelines, the fetus is considered full term at 39 weeks.
I feel more prepared just hearing that list consolidated like that. Now, I want to pivot to something I think is incredibly valuable, bonus section C, commonly confused points. As someone who has analyzed how students fail these exams, what are the biggest timeline mix-ups you see students make when dealing with these specific textbook tables?
There are 3 major tracks that test writers consistently set, and they all rely on students conflating the start of a process with the maturation of a process. Trap number 1 involves the cardiovascular system, specifically the heartbeat timeline. Students constantly mash 3 distinct milestones together. You must separate them. The microscopic heart begins physically beating at week 4. It achieves a synchronized, regular rhythm at week 5. But it cannot be organically heard with a standard acoustic stethoscope until weeks 17-20. Read the question carefully to see which of those 3 specific phases they are asking for.
That is a huge trap, because all 3 answers involve the heart beating. What's the second trap?
Trap number 2 is respiratory. It's the lungs and surfactant timeline. Again, it's an evolutionary progression that students blur together. The anatomical lung buds begin forming way back at week 4. The vital chemical, surfactant, begins production at weeks 21-24. But surfactant isn't fully present in life-sustaining quantities, and the lungs aren't considered functionally mature until week 34. Do not confuse the start of production at 24 weeks with actual maturity at 34 weeks. If the test asks for maturity and you pick 24, you've fallen into the trap.
And the third major trap?
Trap number 3 is fetal movement. We touched on this, but it bears repeating because it's so heavily tested. Table 5A notes the very first microscopic muscular twitches at week 6-7. Table 10.1 notes active, coordinated movement like kicking and swallowing at weeks 9-12. But quickening, the highly specific, highly testable moment when the mother actually feels the movement through the uterine wall, does not occur until weeks 13-16. If the question specifically asks about maternal perception or quickening, the answer is always 13-16 weeks.
Okay, we are in the home stretch of our coaching session. We've gone deep into the physiology. Now we are going to do bonus section D, the rapid review. This is a fast-paced, highly compressed chronological timeline. This is designed for you to listen to on 2x speed right before your exam to get your brain in chronological order. Take a breath and let's run it.
Week 3, the neural tube forms.
Week 4, the fetal heart beats.
Week 6, fetal circulation connects and the liver acts as the blood factory.
Week 8, the architectural framing of organogenesis is done and the placenta is working.
Week 12, biological sex is visible on ultrasound.
Weeks 13, 16. Quickening happens, and the baby actively swallows fluid.
Weeks 17-20, vernix grease and lanugo hair appear and stethoscope heart tones are audible.
Weeks 21-24, surfactant factory lines finally open.
Weeks 25-28, gravity pulls the fetus head down.
Week 34, the lungs are mature.
Week 39, the fetus reaches full term.
Very clean, very fast, very logical.
And to cap it all off, we have bonus section E, the memory talus. We know that humans learn best through narrative and storytelling. So we are going to tie this entire 9-month biological journey together using a vivid, singular story. Close your eyes, unless you are driving to clinicals, of course, and visualize this. Imagine you are the general contractor building a highly complex, customized house.
In week 3, you are on the empty lot, pouring the massive concrete foundation, that is the neural tube.
In week 4, you bring in the main electrical generator and turn it on. The heartbeat starts.
By week 6, you hook up the internal plumbing pipe so water flows through the frame, fetal circulation is established.
By week 8, the entire wooden frame and the roof are completely finished, organogenesis is complete, and you turn on the external solar panels to power the house independently. The placenta is working.
At week 12, the drywall is up, and you decide to paint the nursery either pink or blue. The biological sex is determined.
By week 16, you install a massive industrial washing machine that literally shapes the entire house when it runs. The mother feels the rumbling of quickening.
At week 24, knowing the house needs safety features before anyone can live there, you order the fire extinguishers. Surfactant production begins.
At week 34, those fire extinguishers are fully installed, inspected, and guaranteed to save the house in an emergency. The lungs are mature.
And finally, at week 39, the city inspector signs off, the final inspections pass, the house is perfect, and it is ready to move in. The fetus is full term.
That is a phenomenal way to anchor abstract, microscopic biological weeks to a very concrete, linear, relatable concept. It gives the timeline logical momentum, which prevents the student from getting lost in the numbers.
And that, my friend, brings us to the end of our deep dive into fetal development. I want to genuinely congratulate you, the listener. You didn't just passively skim a textbook table and hope for the best. You actively engaged with the material. You now have a structured, clinical understanding of fetal development. You don't just have a memorized, disjointed list of facts. You know the why. You know that the primitive, uncalcified skeleton forces the liver to make blood. You know that the fetus needs a trapdoor in its heart to bypass the fluid-filled lungs. You know that surfactant is the biological dish soap that breaks alveolar surface tension. And because you know the deep physiological why, you could easily and calmly reason your way through those tricky high-level NCLEX questions instead of just guessing in a panic.
You have officially moved from rote memorization to clinical synthesis, which is the exact skill that makes a phenomenal nurse. But before we sign off, I want to leave you with a final thought to ponder, and it's based directly on a subtle, easily missed note in Table 5b. Earlier, we noted that the digestive system begins forming very early, around week 5, but the table explicitly states that it continues developing until toddler age. We also saw that the myelin sheath, the insulation around the nerves of the central nervous system, continues forming well past birth. We so often think of fetal development ending dramatically at birth, right at week 39. We treat birth like a finish line. But biologically speaking, the text proves that birth is really just a change of location. The construction project doesn't stop, it just moves. So as you move forward in your studies, ask yourself, how much of pediatric and neonatal nursing is actually just managing the continuation of fetal development outside the womb?
Oh, that completely changes how you look at a newborn infant in the NICU or the nursery. The biological construction didn't stop, they just moved the job site out into the open air. Keep that perspective as you continue your clinical studies. We are so incredibly proud of the hard work and dedication you are putting into your education. Good luck on your upcoming OB exams. Trust your preparation, remember the why, and we will catch you on the next deep dive.